Between 100,000 and 200,000 patients will suffer with sepsis every year in the United Kingdom, and a significant number of them will die. More people will die from sepsis than the major cancers put together. The National Confidential Enquiry into Patient Outcome and Death, otherwise known as NCEPOD, undertook a review of the care patients who suffered with sepsis in hospital received over a 2-week period in 2014. The method of review was to ask experts in the field, as we refer to them, reviewers, that's clinicians in intensive care, surgery, nursing, physiotherapy, microbiology, to review individual cases and identify areas of care that could be improved in a patient's pathway from identification to treatment. Sepsis is the way in which a body reacts to an infection. It's an inflammatory response, and we define sepsis, particularly in our study, in 3 ways. Sepsis, where there's just sign of infection. Severe sepsis, where the inflammatory response to the infection has produced a dysfunction in one or more organs of the body. So an example would be the respiratory system was compromised with a raised respiratory rate, the blood pressure drops, so the cardiovascular system is compromised, or the kidneys are compromised in such a way that urine output falls off. International definitions are likely to change in the coming year. Furthermore, septic shock is where sepsis has progressed to such an extent that the patient has a fall in blood pressure, and this is the point at which urgent treatment is required. We felt possibly in our study that the identification of sepsis was delayed, but equally identifying cases within hospital was difficult because of coding procedures. And coding means that when a patient has left hospital, you can review why they've been in hospital, and often people will be coded for the problem that has produced the sepsis rather than the sepsis itself. We were very lucky in this NCEPOD study because for the first time we had 3 general practice reviewers, which allowed us to look at 54 patients who had been seen in the primary care environment. They reviewed the general practice notes and they came out with a number of findings. Firstly, in common with secondary care, they recognised that there was a poor ability to record vital signs in patients seen in the community. And the benefit of this was well recognised, and it would allow their colleagues who follow seeing the patient perhaps on a subsequent encounter to recognise that there was deterioration. Also, we recognised that they weren't using pre-alerts. Now, hospitals declared that they had a system to allow general practitioners to pre-alert them of 6 patients coming into hospital in 51% of the hospitals, but only in 9.4% of patients that the GPs reviewed was a pre-alert used. So this demonstrated that communication between primary and secondary care could be better. There were also deficiencies noted in referral letters. And so the more information that's passed between primary and secondary care will undoubtedly enhance the care a patient receives when moving from the community to a secondary care setting in hospital. On admission to hospital, patients were reviewed commonly in the emergency department. We identified that there was a delay in their treatment and indeed the measuring of vital signs in about 40% of patients. Now, the Sepsis 6 is a protocol that ensures that patients identified with sepsis are treated promptly and with the correct modalities of treatment. The Sepsis 6 describes 3 things that you give and 3 things that you take. So the 3 things that you take are you measure blood lactate, you measure urine output, and you take blood cultures. Now this is a sample of blood that hopefully will grow a bug that is causing the infection or a pathogen. The three things you give are you give the patient oxygen, you give them fluids, and you give them antibiotics. We demonstrated that there was a delay in 40% of patients within the emergency department to receive all modalities of the sepsis 6 pathway. Now, there is a well-documented study that shows that delay in treatment of patients with sepsis increases mortality. In those with septic shock, it is demonstrated that every hour's delay in treatment increases the mortality by 7%. So it's important that patients are treated promptly. Another thing we noted was that there was a failure in about 30% of patients for them to receive a senior review, and that's a senior clinical review. And what we found was that when a patient was reviewed by a senior clinician, the senior clinician actually changed the treatment pathway in 60% of cases. And that's a significant amount of change, which demonstrates the benefit of patients receiving early senior clinical input. Just Say Sepsis, the NCEPOD report that looked at patients who were diagnosed with sepsis both in the community and in hospital, makes a number of recommendations. Firstly, we recommend that hospitals have protocols to aid in the diagnosis and management of patients with sepsis. These protocols should be freely available to clinicians. Clinicians should be given training in their use, and hospitals should undertake audit to ensure that these protocols are used properly. Secondly, we recognise the benefit of early warning systems, both in primary care and secondary care. In primary care particularly, the use of vital sign monitoring and their accurate recording of vital signs aid in the use of an early warning system. Thirdly, clinical review, particularly in hospital where senior clinical review is important. We recommend that patients are seen by senior clinicians within a suitable time frame as laid down by the Royal Colleges. They should also ensure that handover between clinical teams is robust and policed. There should be access to critical care for all patients with sepsis. And we recognise the benefit that hospitals have with critical care outreach teams who played a significant part in the management of patients with sepsis, both in the hospital environment and promoting their admission to critical care. And finally, the use of clinical pathways, both for those with sepsis and, as we demonstrated, particularly for the management of the source of sepsis, should be promoted throughout hospitals and primary care. Just Say Sepsis is an NCEPOD report that looked at 551 patients with sepsis. Throughout the patient pathway, we uncovered an enormous amount of data that will be of benefit to clinicians treating patients both in primary and secondary care who they suspect or indeed know have sepsis. If you want to find out more, a link to the report in PDF format appears at the end of this video.